the announcement that there's food and beverages on the table. Please help yourselves. The refreshments are paid for because of generous funding from the Internationalization Department, which runs this house. Right. Enjoy.
So first of all, thank you all for being here. We have the presentation divided into a couple components. For those of you who know Maria Jose, for those of you who know me, I'm Sandy, that's Maho. The work that we were doing this summer is the 4th year of work that has been done by the Global Health Affairs Program at the Joseph Corbell School of International Studies. And so what we're going to do with the presentation is I'm going to kind of set you up for what the overall project is, and then hand over the presentation to Maha so she can speak very specifically to some of the work that she was doing this summer. This summer we had 2 graduate students that were working in the field, Maho, and for some of you who know Greg Malley, who recently got a job back at USAID. We had 2 graduate students there working this summer, and again, this is the 4th summer that we've had students doing work with our partner organization in New Delhi. As you can tell by the title of the presentation, I'm going to talk to you a little bit about maternal health care in the catchment area that we're working in, basically in 5 slums in New Delhi. And the wonderful photography is courtesy of Maho. When we were putting together the presentation, Maho said, you know, I think it's a really great idea to give people a more visceral sense of where we were working. So you're going to see kind of photos throughout the presentation, and again, courtesy of our photographer. So before I just give you background on the project itself, just to kind of set the stage, this was part of one of the slums that we were working in New Delhi. This was an area called Jasola, and if I'm remembering correctly, this was actually taken from the 2nd floor where the office was that we were working out of. So you can kind of get the condition. I'll talk a little bit about some of the distinctions in the areas that we were working, but Jasola was one of the more well-developed slum areas where we were working. And I say well-developed because this area was over 100 years old, and you can see that we actually had a concrete building, we had electricity, although of dubious quality, in various areas, pretty narrow streets, fairly undeveloped, and during the rainy season, quite a bit of a mess to get through. You'll see photos kind of later on of some of the issues with water. Again, just one of the very typical walkways in Jasola. In terms of what we're trying to do this summer, this is a bit of a larger project where we're working with our partner organization, and the idea is to try to introduce technology in a sensible way to try to impact some of the maternal child health outcomes that we're seeing in the slum areas of Delhi. Very specifically with the project, we were looking at really 2 outcomes related to the summer. The first was to try to understand how to utilize technology to create efficiencies for some of the caseworkers who are working with pregnant women in the slum community. And then the second part was to actually come up with a plan where Randall and I are now in the process of applying for grants to see if we can do a proof of concept for the plan that we talked about. You'll see these later on in the presentation, but the first part, again, trying to come up with a more efficient program for our case managers to better reach women, pregnant women in the community. Really trying to look at some of the technological mobile applications that we had, trying to create efficiencies in terms of entering women into a continuum of care for health monitoring and health follow-up, trying to reduce redundancies in paperwork, and most importantly, trying to make it easier for the case managers to locate women in the slums. And we'll touch a little bit on that in the presentation, but hopefully you'll have questions at the end, because, again, big project, we don't have a lot of time. What we I think the really important output that we had from this summer was coming up with a system whereby we're hoping to integrate 3 different partners that are delivering health care or trying to deliver health care to Dalits, kind of the lowest caste in India, living in the slums, trying to more efficiently link them to resources for improving maternal and child health care, and also trying to create a better flow of information through the different organizations that are delivering health care to women in these areas. Basically, to kind of contextualize the problem, globally, about 350,000 women a year die from complications that are related to childbirth. And maternal mortality is one of the goals that we've been attempting to address in the Millennium Development Goals, and it's one of the goals where we've really had the least success. We've seen some changes in terms of maternal mortality, but every report that's been written looking at are we going to achieve these goals by 2015 has been saying maternal mortality is one of the areas where we as a global community haven't done a particularly good job. When we think about the maternal mortality rates, 19% of the global total are deaths that are occurring in India. So this is huge. We're seeing India contribute essentially a fifth of the global deaths. When we're looking at maternal mortality, and what's even more kind of shocking is when we look at the causes of maternal mortality, what we're seeing is about 80 to 90% of the maternal mortality deaths could be prevented through relatively low-cost interventions. The number one cause of maternal mortality we're seeing is hemorrhage, and basically the hemorrhaging complications can be prevented with appropriate follow-up, appropriate early detection, and if we actually see women being attended to by a trained physician. Again, when we look at what we know about maternal mortality globally, we know that some of the effective prevention strategies include antenatal care visits. The global standard is women following up with healthcare professionals at least 4 times prior to giving birth. Having at least one visit with a birth attendant to talk about planning for birth, having some idea if you go into labor, how are you going to handle that? Do you know where to go? Do you know how to contact the people that need to be contacted? Do you have the transportation to get there? So having a birthing plan. We also know that actual attendance by a skilled birth technician, relatively low cost, tremendous impact in terms of preventing maternal mortality. And one note on this for the non-GHA people, we're talking a skilled birth attendant, not necessarily a medical doctor, but we're talking somebody who has essentially been trained in recognizing problematic births, making appropriate referrals, and also been trained in relatively simple interventions when we do have breech births. The other intervention that we've seen is very, very effective is access to family planning. We're seeing a number of maternal deaths are associated with complications from abortion, from unsafe abortion. So again, taking you back to Jasola. So we know, again, maternal mortality, huge issue, and it's an issue where we have the tools for prevention. Now within India, what we know about maternal mortality is the problem is exacerbated for poor women, and the problem is most prevalent in urban areas, where we're looking at urban slums. Those of you who work in development, you know that many times we talk about the idea that often healthcare is much worse in rural areas than it is in urban areas. Well, what we see in India in terms of access to appropriate health care, conditions are much worse for poor women living in urban areas than they are for women in rural areas. Overall, again, we're seeing that there's fairly high level maternal mortality. Our maternal mortality ratios, we're seeing about 200 women die for every 100,000 live births. That's quite high. Now, this number has come down in India. In 1990, we saw about 600 maternal deaths per 100,000. And again, what we've seen with success in India is increased access to service, increased access to antenatal care, and increased access to birth attendance by a trained birth technician. The other thing that I think is really stark, those of you who are in my class, you know what proportional mortality is, but 7% of the deaths that are occurring in women of childbearing age are occurring because of complications related to pregnancy. That's really quite high. We also know that in India, for every 1 death, we're seeing 20 women who have lifelong complications that are associated with problems giving birth. Again, looking at India, the poor really do have worse health outcomes in relation to maternal mortality. And what we're seeing is about 2/5 of the deaths in poor women are associated with hemorrhage. And again, hemorrhage is something that we can prevent through appropriate planning prior to giving birth. And we can respond to, we can provide acute care if we have the attendance by the appropriately trained technicians. We're also seeing, again, some of the problems that are associated with maternal mortality in India are really related to lack of access to these low-cost interventions. And only about 14% of the women give birth in an institutional setting. In terms of the slums, again, looking at the urban slums, looking at the urban poor, we have tremendous issues, again, in terms of accessing the interventions that we know can help prevent maternal mortality. One of the numbers that we see, women living in the slums are 20 times less likely to access antenatal care than non-poor women living in urban settings. That's really quite high. A number of studies that have been done in slums throughout India and studies that have been done in slums in and around New Delhi have shown that the majority of the maternal deaths are associated with underutilization of service. And so one of the things that we have to ask is, why are women not utilizing the services? And in some cases we have lack of availability of services. In some cases we have lack of affordability. In some cases we have women not able to essentially pay for the transportation to attend the antenatal clinic, or to pay for the transportation to access a hospital or a clinic. And more what we're seeing is there are cultural factors that are coming into play. Cultural factors: what is the woman's role? Is she outside of the home? Does she have someone to travel with her to different clinics? Again, this is very much dependent. I would say this is neighborhood dependent, because we have so many different religion and cultural beliefs kind of under this catchment area in New Delhi. But we also have huge stigma associated with the Dalits. Again, by and large, when we're looking at the slum area, we're looking at the lowest castes. Not the lowest caste, the lowest caste. And so even where we see services available, we have problems with people going in to receive care and being treated badly and never going back. Or we have a problem with people who have been essentially so badly abused by the system that there's not a willingness to go and seek care, because why should I subject myself to this humiliation? Again, I mentioned, one of the problems that we have is actual access to services. This is another snapshot of Jasola. This wasn't after one of the particularly hard rains, but you can kind of see it's not really a great environment, not a great environment to be walking in. Very difficult. We have a couple of cars. By and large, we're relying on tuk-tuks and the bicycle rickshaws to get around, assuming one has money for those. Otherwise, you're walking through mud. At one point in time, we came in, and this whole area was underwater, and we essentially paid a tuk-tuk driver to carry us across it, because we didn't want to step in it. The water was actually very close to an open sewage, and we're a little persnickety. So anyway, there's some issues with that. Now, the situation in India, it's really quite interesting, because what we have is a convergence of a couple of different ideas in terms of healthcare. Maternal mortality and early child mortality are problems that have been targeted by the national government for addressing. We also have a situation where, under the Indian Constitution, access to health is considered a constitutionally guaranteed right. And India, for all of its, I'll say, craziness, is a pretty amazing example of a democracy that functions and sometimes doesn't function so well. But we have, again, this constitutional right to health care. We also have the acknowledgement that one of the biggest issues with health care is linking the poor to health services. And so what we had established by the national government and then added onto by the government of New Delhi was essentially a public insurance scheme, through which anyone who is an Indian citizen had the right to access health care. Which brings us to kind of another thread of what we're looking at in this project, and it's a thread that's looking at public-private partnerships. When we look at healthcare in India, again, we've had this acknowledgement by the government that we have a lot of needs in terms of health, and we're talking access to primary health care. We're not talking tertiary care. And the government doesn't have enough physical clinics, enough physical hospitals. It doesn't have the money to pay for the care. It doesn't have the human resources to provide care for basically our billion population. But these resources exist in the private sector. And so what we've seen with the Indian government is essentially establishment of, or an attempt to establish public-private partnerships to allow for healthcare provision. And some of these structures are essentially placing a tax, if you will, on private providers of healthcare, whereby in order to set up your building, in order to operate your building, you are expected to provide a certain number of beds and a certain amount of treatment for free to the underserved communities. Now, where we were working in Jasola, we were not quite within spitting distance, but we were right, probably a 10-minute ride by tuk-tuk from Apollo Hospital. Those of you who know Apollo Hospital, it's the largest purveyor of healthcare in India. It's one of the largest private purveyors of healthcare, and they do these wonderful medical tourism packages. Interestingly enough, well, that's another conversation. They should be providing some free care, and they're not. So again, we have this idea that through public-private partnerships, there's going to be increased access to health care. We also have the government of New Delhi saying, okay, we understand it's not just a question of sending out insurance cards to everyone and saying, poof, you get to access medicine. It's actually a question of educating people about what their rights are, educating people about where to find resources, educating people about their legal rights, and engaging in empowerment, particularly in these disempowered communities, particularly when we're looking at the folks that live in the slums, who have been so ostracized from society. They need somebody there. They need an advocate there to not only tell them what they can do, but to help them navigate quite impressive bureaucracy, and to navigate kind of the social obstacles. So within that, and I'm almost turning it over to Maho, I've been talking for way too long. Within that, just to kind of contextualize, in New Delhi, essentially the government has provided funding for case managers, community mobilizers, to reach out to different slum communities. They have different roles, but it includes education about legal entitlements, advocacy in terms of obtaining proper paperwork that shows you are a citizen and you can access education and healthcare and any type of legal document that you need to own property or even to rent property. So we have the government essentially providing funding and saying we want to build this awareness, but they're doing this by engaging in public-private partnerships. Government of New Delhi was actually working with New Concept Information System, which is a for-profit corporation, and was the parent organization of the group, one of the groups that we ended up working with. New Concept has a not-for-profit arm that has been doing education and empowerment in the slum community. And this not-for-profit arm is actually working with the Gender Resource Center, which is managed by New Concept, but it's funded by the Delhi government. So it's a really interesting example of a public-private partnership. The only thing that I'll say about this is one of our tasks is to actually understand how to incorporate these systems. Probably won't talk a lot about that other than to say it's a daunting task, and we spent a lot of time trying to get different parties to trying to understand how New Concepts viewed the Gender Resource Center, how the folks at Gender Resource Center view New Concepts. And again, partnership with University of Denver that has allowed our students to go mostly over the summer. I think we also had one student go during winter break at one point in time. We're really providing research. We are not there to tell people how to do their jobs. We're providing research that is asked for to help the system flow more efficiently.
And so Delhi has 124 gender resource centers, and each one works with different for-profit or for non-profit organizations.
So the Gender Resource Center that we're working with, you can kind of see, here's a map of New Delhi. We're working in an area kind of to the southern part of New Delhi, actually right on the border with another state. And the Gender Resource Center that we're working with provides outreach to 5 slum areas. This summer we were focusing on one. We were focusing in the most easily accessible and the most developed of the slum areas. It was also the slum catchment area in which the Gender Resource Center is located. So I would say in terms of access, this was the slum where there's essentially easiest access both for the community to health services and for the service providers to the community. The Gender Resource Center provides bi-monthly antenatal clinic, and they also provide a mobile health clinic. Most of this you don't really need to know. What's really important to know from baseline data that's come from 2 years of surveys in this 5 slum catchment area is that by and large the women in these slums are not accessing antenatal services. What we saw is that, let's see, where's my bag? Those that have had maybe one antenatal service, about 73%, which is actually good. Those that have had 3 or more visits, antenatal visits, about 37%. So actually well below kind of what we're seeing in India in general. We have average of 3.1 pregnancies. Less than half are delivering at a health facility. Majority of births are at home, and the majority of births don't have attendance with a trained technician. So again, we have this kind of large project. When we went in this summer, we really wanted to do a feasibility study for utilizing technology, trying to understand if technology would provide an advantage in terms of connecting women in our catchment area to services. And one of the things I forgot to mention that we found in previous surveys is that, interestingly enough, in kind of the slums that the JRC is working in, it's not a question of there being a lack of healthcare facilities. what we're seeing is women aren't accessing the healthcare facilities. And they're not accessing the healthcare facilities in part because of knowledge, that they can access them, in part because of lack of knowledge about where they are, and in part because of some of the cultural barriers that we're seeing. And so, one of the questions that we had as well, we were essentially asked, well, can we use mHealth technology? Can we use cell phone technology for our caseworkers to better interact with women and to better connect women in our catchment areas to facilities? And that was really what kind of one of the big goals of was for the summer. And with that, I turn it over to Mom.
Okay. So we wanted to know why women were not accessing health services, because that was one of the main reasons that previous research had found that was going on. And as you can see in the map here, this is the map we did. There was no map before. Let me see, I forgot to put the key. But I think all these are pharmacies, and the little houses are Anganwadi centers, which are places where they can access nutrition and vaccines and education sometimes. And I think these are like, I don't remember, I'm not gonna lie. So my main task, my responsibility was to do the qualitative research part. So I decided to do focus groups, because it's more, I enjoy it. I really enjoy talking to people. And so I did a focus group with the GRC staff first to understand their own perspective on health and maternal health in the communities they work with. And they've been working for in like 15, 20 years. Because not as the GRC, but they've been working there for years. And also focus groups with mothers. Because people know more than we usually think, and they know more what they usually think they know. And so we did focus groups on child health and also on maternal health. So what I'm presenting here is more on maternal health because that's what we decided to go for. So in total, there were 19 women from the Jasola area, 10 in one group and 9 in the other. All of them were mothers, and they had from 1 to 6 children, alive children. And in one group, there were participants from a self-help group, which is like an cooperativa?
Cooperative.
Exactly. So easy. And I forget the easy words. And then, so these women work together to have money and loans when they need them. And they organize for other things too. And we'll see how that really affected the knowledge they have and how they participated. And then the other focus group was of non-members. And then with the GRC staff, in total 7 women participated, and some of them live in Jasola, some of them live in the other slum areas, and 3 of them are mothers, and they have 1, 2, and 3 kids. And so the main issues explored in all of the focus groups were, we wanted to know how much they knew, the level of knowledge about maternal health issues, their perception of the available health services there in the area, and like Sandy said, a hospital, the biggest hospital is 10 minutes away, and then there's another one that's like 20 minutes away. Plus like clinics and health centers, private clinics. And then to ask them what would be the ideal service for them so that they could access it. This is one of the women that attended one of the antenatal health clinics, and she let me take her picture, which was nice. And so some of the results from the focus groups, so I was trying to explore and understand how they perceived severe and mild diseases and how they differentiated them. Because once you know a mild disease from a severe one, you make better decisions on when and how to access health services. And so I asked them, what are the mild diseases or illnesses that affect women that are mothers or that are pregnant? And so the GRC staff said back problems, weakness, urinary infections, and fainting. And then the first maternal health group said headache, vomiting, no eating, fainting, and you can see some of the similarities. And then the last group, which was one of the hardest focus groups I've had to do in my life, it was stomach ache, vomiting, laziness, and backache. It was a very interesting contrast. And then for severe diseases, it was again urinary infection because it can get worse, anemia, white discharge, and multiparity, or because they have no time to recuperate. And so the GRC staff, although they are not midwives, they're not birth attendants, they're not nurses, they know a lot of things. And a lot of people come to the GRC to receive information and on citizenship, on education, on health. And so they can give them information. Like, you feel this, go now to a health center. Severe diseases for mothers themselves were the fear of abortion. They didn't say abortion per se, but like the fear of that. Weakness, bleeding, jaundice, anemia, weakness, and white discharge. So you can see some of the differences, and I mean, they're all important, but the level of knowledge is different in each. One of the phrases that came out of one of the focus groups when we were saying like what would be like key education messages that you could give women so that their like family is healthier. So healthy woman, healthy child. India, and I would say like Delhi, and working in urban slums and working with women from the lower castes is very interesting and difficult because they don't see themselves as that important. Some of them do, but some of them would like stop eating to feed their kids even when they're pregnant. Like any mother would do that probably. So one of the messages is if you are healthy, your whole family is going to be healthy and happy. And so we did some skits with the women. So I asked them, like, you're pregnant, like, right now. Like, you just found out you're pregnant. What will you do? And it was funny because it was in Hindi, but I could understand, like, body gestures, and it was really, really interesting. And so some of them were resting, some of them were eating, some of them were working, and other women came and told them, like, no, like, you're pregnant, you should rest, and da-da-da. And then I was like, how often does this really happen? Like, you know the information, but how often do you really rest? They're like, oh, no, it depends. Like, some families are very, like, not good to pregnant women. So they started telling their own stories. Some women would prefer going to doctors, but others to traditional midwives, to DICE. Some of them talked about how they go to a doctor and then they have to go to get an ultrasound and then they have to go back to a doctor. Every time they're paying for transportation, for the fee that they get charged. Then they have to go to a pharmacy and get the medicine. So it's really complicated. It's something that we would naturally do, and if you have a friend or a wife or something that's pregnant, you would do that. But imagine yourself in that slum area where there's no transportation or no easy transportation. And then in some of the skits, they were going to a hospital, and then most of them were saying like, no, it's better to get a delivery at home. And it makes sense. And the importance of breastfeeding. And so what were the main barriers to them of seeking health? The lack of money, especially in private hospitals. But at the same time, they often prefer going to a private service because in the public hospitals they won't receive enough attention. They'll make a line for hours. If there is no hospital nearby, they won't go. I don't know how to pronounce that. Savdarju, I think. So it's one of the public hospitals. One woman stood there for like an entire day. And so the public hospital has free care, but there's no attention. And then the GRC staff said that they can work on prevention and health issues, but still you saw the pictures from the pigs and the kids with the garbage. It's all the time. It's an open sewage system. So no matter how much work you do, the government also has to start working. That's what they shared with us. And so, finally, I mean, women definitely know best. It was more visible in the focus groups on child health, because they decided like what they would do in certain cases of child disease. So I told them, like, you are the experts, you're moms, you have been moms for 3 or 4 kids, and so they know the symptoms between mild and severe diseases. They know what kinds of treatments or ailments or even attention to seek. They also perceive a very clear difference, and even though it seems logical to us, hearing it from their mouths and hearing it from their own experiences, how public and private services are very different, is really important. And the GRC was like an important community center, not only health-wise, but it's like an important social place. And finally, they need places they can afford, places they can get to, and where they can receive attention. And these 3 points are the 3 delays for maternal mortality. If you treat the 3 delays, you can reduce maternal mortality. And so this is the GRC. It was one of the days for the ANC clinic, I think. And they welcome every woman. They like put their name down and they weighed her, and then it's a very social event. It's really, really interesting. I'm an anthropologist, so that's I don't know how I can just show the pictures. Awesome. Yeah?
I'll summarize this thing for the pictures.
Yeah.
So, because I feel like I have to do the conclusion. There's a lot that I couldn't talk about, and one of the things that we were also trying to find out in focus groups, we were really trying to understand how the different actors in this community understood each other, and trying to understand, we found actually quite a great deal of misperception between the organization that's managing the GRC. GRC had fairly clear understanding of what women in the community understood, what they didn't understand. Like Maho said, women in the community seem to be very on top of taking care of their children, but there is a lot of, I would say, misperception and opportunities for intervention in terms of taking care of themselves during pregnancy. The other thing that we were trying to understand is the utility of technology. Is it going to at all facilitate either allowing the case managers to better locate women in the community, or allowing women in the community to understand where they can receive appropriate services? And again, one of the things that we saw is that there were really 2 places that women knew where to go. They didn't know where else to go, and there were some services that were available that, in theory at least, were not going to cost them anything. They weren't going to have to pay a fee to receive services there. So, kind of the big thing that came out of this summer was understanding that the stakeholders that you should target the technology for are the community mobilizers. And the big issue that came up is the community mobilizers, typically their point of contact with the women who are presenting as pregnant is either perhaps once during the mobile clinic or perhaps once during the ANC. And everything is happening with the system. It's paper-based. It's difficult to follow up with the same women across time. The paper, in theory, from the mobile clinic is getting filed with the paper from the ANC, but the reality is that's not necessarily happening. The reality is, again, you're getting into issues with names. You're tracking people with names that it's easy to get redundancy, but it's not the same person, or it's easy to get the wrong name in terms of how somebody's presenting their name. So there's not a consistency in follow-through with the patients, and also women aren't coming back to the clinic. The community mobilizers, it's their job to continue to remind women to come to the ANC clinic, and they said, well, the hardest thing in the world is, 1, to follow the same woman through the system, and 2, to find her. She comes in, she gives an address. Maho said we ended up mapping Jasola. The map didn't exist before. Of course, you can't do Google Docs and pull up the map of the slum. And what the women told us was, they come in, they give us a name, might be their name, might be one part of their name, and they tell us the building, and they tell us the building's name based on the landlord. So we can't really find them. And what we want to do is we want to start asking them, well, what landmark is near your building? And we want to map those landmarks. The idea being, rather than spending 2 hours trying to find one woman to follow up with her, it becomes easier. You find that woman in 30 minutes, and then you spend more quality time with her doing advising. So that was one of the ideas, is essentially linking a mapping system to an electronic intake form. The electronic intake form can be shared between different organizations that are providing services, so we start to have a consistency. So again, the key is linking women to services, coming in part through digitized records, and it sounds really unsexy and really boring, but sharing those digitized records across the different service providers in the area. Integrating service delivery, the case manager better being able to locate women and link them up to appropriate service delivery, and then ultimately, hopefully, seeing an impact on improved maternal child health. Yeah. So, how's this one?
There we go. Oh, this is what we. So so the interesting part about the mapping was that the community. So Greg trained us all in how to use the GPS, how to mark the points. So we marked all the mosques, the pharmacies, the Aganwadi centers.
So, the streets don't have names.
Or houses.
Or houses. And so, again, the community mobilizer said, well, we need to mark landmarks that everyone knows. They were the ones that knew what the landmarks were. And so they kind of turned loose to map their community.
And that's the team. Yeah. So yeah, that was the project. We were originally going for cell phones, but women don't, there in Jasola at least, don't have a cell phone. M-Health technology has worked in many places in Africa, but here it was not the case. So we went for a map that could be shared, and a map that the GRC could have there in the computer they have in the office. And so when women come and tell, oh, I'm pregnant, or like my daughter is 3 months pregnant, and we live near blah 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 mosque or pharmacy or school, then the GRC staff can tell her, oh, the nearest health center is right there. It's in the map. So there's a lot to do still. We only mapped one of the slums. There's a lot of training to keep on doing. Next summer you should go. Apply. I trained them on focus groups and how to design the focus groups and analyze and systematize to just have tools that you can use in the future. We did a lot of participant observation. We went to 2 ANC clinics, to one of the health big events they had, and we did some informal interviews as well. Yeah, and so this is one of the ANC clinics. So the GRC has 2 spaces, 3 I would say maybe, and they have a space near a school, so there's always movement and noise and people coming in and out, and the focus groups there were very hard. And so they're in this computer, they were registering some people. He's giving them some of the medicine. Women are coming in, and then in this side where you can see in the picture, women were being checked by a pediatrician and by a nurse. And then the other room is for kids and for education and vocational education. And so this is one of the women waiting after seeing the doctor, waiting to receive her medicine. And yeah, that's it.
Thank you both very much for the presentation. We have some time for questions. I'm sure that there